I would now like to introduce Dr. Rod Barillo and Peter Wolf. Dr. Barillo is the Corporate Director of Education for Hospice of Michigan and has more than 30 years of very strong clinical and educational experiences in hospice and palliative care, emergency care, home care, correctional care, and education. He has been associated with Henry Ford Health Systems, Detroit Receiving Hospital, the Wayne County Sheriff's Medical Department, and the University of Detroit Mercy. Dr. Barillo continues to consult and present at the local, national, and international level. He has also been a very big help to VCE with our continuing education program committee. Peter Wolf currently consults with Metro Detroit Head Start, the Department of Human Services, and facilitates a grief support group series and conducts psychotherapy with children and families in a private practice. Mr. Wolf has presented at a large variety of conferences, universities, and hospitals on topics related to grief, loss, and end-of-life issues for students and social workers and other medical professionals. Please join me in a warm welcome for Dr. Rod Barillo and Mr. Peter Wolf. Thank you.
Good morning. And you'll get to see Dr. Barillo in a few minutes after, well, 40 minutes. We got this timed perfectly. It's an honor and a privilege for me to be here because of the audience of wonderful professionals in various fields of healthcare, both mental health care as well as physical health care. So it's an honor and a privilege for me to be here as a colleague sharing in the work that we do. Good to have you here. Is also an honor and privilege because of all the behind-the-scenes people here. They have been fantastic. I feel like I'm flying a 747. I mean, I've been prepared like a rock star with the technology and so forth, so it's great. In my presentation, I tried to keep this as basic as possible in the sense of you have copies of this presentation in your folders, and so you can do with it what you want. But just a little footnote with how I do PowerPoint and how I present off of PowerPoint. In actuality, the PowerPoint is a lot for me to keep me on track and to keep me within the time frame. And so as I go through the PowerPoint, I might not hit everything that's listed. I'm assuming we're all adults and can read, so that's why you have them in your hand. And so if I'm going through this and all of a sudden you go, hey, he didn't talk about that, or he didn't talk about that, that's okay. I mean, this is the way that I go through my presentation. But if I miss something that you definitely have a question about, please somehow get in contact with me. I have contact information at the end of the PowerPoint, and you have that in your folders. Before we get into this, the topic of children's reaction to the death of a parent, I want to invite you to get in touch with the child within. And before I do that, as was announced, you have pads and paper to write down questions. So this exercise is only going to take 1 minute, a half a minute for each question. The first question that I've got for you that I want you to take a half a minute, and I'll keep time on that, is what question, when you see this title, what question do you want to make sure is going to be answered? So I'll give you a half a minute. Write down a question that you want to make sure is going to be answered at the end of this presentation. Okay. For those of you who want us to respond to that question, like the announcement was made, those questions will be picked up so that we will get to respond to them, or at least most of them. Now, the second question is, and I want to set the scene first, and I'm going to invite you to, in your mind, go back to your childhood. Go back to any time between, as far back as you can remember, so for some it might be ages 2 or 3, all the way to about 17, 18 years old. So stay within that time period of your life. Recall a moment when the presence of your parents or parent or caregiver was significantly present for you. Now, it could be at a school recital that you were the main speaker. It could be at a play that you were an actor in. It could be at the first Christmas that you remember. It could be at any event in your life, but pick one of them in that time frame when your parent was very significant and their presence was very important to you. Okay? Now, remember that time and take the parent or the caregiver away. Now I'm going to give you a half a minute. Ask the question you want answered before the end of this period with that mindset. For your eyes only, is that question different than the first question? Is the question of what you want to learn here or an experience, whether it's your own or the person that you're working with, do you approach it differently as an adult or as an adult that understands or gets into the skin or gets behind the understanding of the child? So in other words, as you look at these two questions, they should be different because of the different focus, the different where you're coming from. If they're radically different, more than likely you're going to be able to catch on really fast to what I'm saying and what I'm inviting you to use in the field. If it's not radically different, granted there are some overlaps in the sense of perceiving death as an adult as well as perceiving death as a child. But hopefully, if there isn't much difference, that by the end of this session, there will be much more difference, because you will have a greater understanding that a child perceives death differently than an adult. And time goes by fast. We became adults really fast. The caution with that, especially when working with children in death and dying, and specifically the death of a parent, it is critically important to at least scratch the surface of what it must be like for them. Because grief and loss has much more intense feelings, emotions, fear of extinction, of not surviving. Why? Because that adult is the key caregiver that protects me, takes care of me, provides everything for me. And if you take that adult out of the picture, it's a lot different than you and I now as adults experiencing the death of, let's say, a parent, a brother, sister, or even a child. All death experience is difficult. But if we're going to understand and work with children that experience the death of their parent, it is important to remember and to get in touch with our child, with some of the memories that we have of death and dying, because that's what we bring. That's what we bring into that either therapeutic environment, group environment, family environment. I divided the presentation up into 3 areas. The first area is understanding or assessing what's going on in the scene when I walk into it. Already from the time that I'm informed about it, either like for my experience in private practice, if someone calls and says, I want to set up an appointment, for other people's experience in the sense of a supervisor saying, this family needs work, they have children, the parents have died, or a parent has died, this is your task. So however the information comes to you, you walk into a situation that you have to have a vision of 360 around to perceive what's going on. That's the first part. The second part is hopefully nuts and bolts suggestions that you can take with you into those situations. Some of these suggestions you've probably already tried or have worked with. Others might not be. But I want to give you something concrete to walk out of here with so that it isn't just all assessment and theory, that you actually have something to hold on to. The third area is delving into specific deaths, such as suicide, such as homicide, such as death due to a transmittable disease. These deaths affect children in yet another unique way. It isn't just the death of a parent from the child's perspective. It's the death of a parent from a child's perspective that the society, the culture around them might have a totally different reaction to. And I'll get into that a little bit. Hopefully my timing is right and I'll be able to move along, but that's the last part. Again, if I don't get to it and answer your questions that might come up in light of that, contact me and we'll fill you in and get you information on that. Overall, these are the goals and objectives. Culture, definitely. What I want to highlight with culture is it isn't specifically race-oriented. Race could be a part of it, but when I'm talking about cultures, I'm talking about the bigger picture of cultural environments. And so, in other words, you could have similar speaking people, say Spanish or Arabic. And within that community, there might be several cultural environments, such as affected by income, affected by rituals, affected by family attachments. So the point is that culture is the bigger picture. And I'll get into that. In assessing the culture, it is important to be aware of that just because two groups of people speak the same language, or two groups of people have the same color skin, or two groups of people come from the same part of the world, doesn't mean that they share the same culture. So each situation cannot be assumed. Each situation that we walk into, we have to be aware that there's always going to be something new that family system, that child is going to teach us about what it's like growing up in that culture. I'll just flash through these. These are sayings that I've taken from several books. I like the sayings, but also if you're looking for books that are really good resources, these are some of the references as well. So, what's the role of the parent? And this hopefully is what happened to you as I was inviting you to consider those questions, in the sense of the shift from perceiving death from an adult perception to a child's perception. When a child experiences the death of a parent, they experience the loss not only of another human being, but the loss of a sense of safety and security. Who will take care of me? Who will feed me? Who will take me to school? Who will wake me up in the morning? Basic elementary questions, but they're huge for a child when a child loses a parent. Who's going to teach me? Who's going to guide me? Who's going to be my coach? Identity. How much of our identity is, as we sit back, even today, as I was preparing for this talk, I was thinking about my own childhood, and thank God my parents are still alive, and wrote them a letter expressing what I'm going to be doing today and how much I appreciated what they did for me as a child. It gave me an identity. If they're not there, where do I look for my identity? What the child knows. There's various stages that I'm going to cover, and you can get into even more detail if you want to. There's other resources, but because of our time and because of the nature of our presentation, I'm going to go over these three areas of children's developmental stages and how they perceive death and dying. Obviously, in the early childhood, it's very egocentric. A latency age, age of imagination. One of the reasons why, cartoons, books like Harry Potter are exciting is because, especially for this age group, because it delves into the imagination, the fantasy world. Young people, adolescents, and teenagers. Nothing can scar them. Nothing can challenge them more than what they can take on. They can take on the world, and especially when death and dying happens. And I'm going to get into some of what are some of the pitfalls that we might happen to us when we work with teenagers, such as, they're not talking, so they must be dealing with it. Not true. So, one of the things that I want to highlight with early childhood perceptions of death and dying is, in that first part, concepts of death. From ages newborn to about 4 to 5 years old, these four basic concepts are being developed. So reversibility versus irreversibility, meaning that a child in that age category is going to talk about, mommy or daddy are coming back. Or I had a child in that age group that said, I'm going to go visit mommy at her new home in the graveyard. They perceive death as something that's very significant because of how all the people have reacted to it, because that person is not there, but they're somewhere. And so children in that age category will use language that is in many times the present tense. Let them use that. That's where they're at. I would not recommend trying to change that. And here's a footnote on the side. With any of this interaction and processing and work that we do with children, a key thought to remember is catch yourself if you're doing more of the talking. Because when children experience death and dying, they may have these really difficult questions like, why did it happen? Or they might even have a religious question. Why did God let this happen? And if there's anything that can confront us, it is a child's question about death and dying. You don't have to give a long, detailed answer. A simple, basic answer, and sometimes that answer can be, I don't know, but why don't you tell me what you think happened? My point is that children really want to talk rather than have you talk. And so our job is, how do we open those water gates? How do we open up those emotions, that story that's formulating inside of them, wherever they're at, whatever their perception is? Non-functionality. They walk up to a casket, and by the way, I recommend, many times parents will ask me, do we take our children along to the funeral? First of all, my question back to them is, and here's where the cultural assessment comes in. I ask, what has been your practice as a family? I don't want to violate that. Even though my preference is, you bet, bring the kids along, bring everybody along. I mean, you bring kids along to birthday parties, that's the flip side of the coin. A 1-year-old, an infant, a newborn, doesn't understand happy birthday to you. So why do we bring them to birthday parties? How else are they going to learn? And so the flip side of the coin is true too. If we don't bring our children to the funerals, to the wakes, how are they going to learn to grieve? They watch us. The key here is, it goes back to what I put up as the role of the parent. The role of the parent is a source of safety and security. So yes, you bring the child along to whatever are the rituals of death and dying, but you don't leave them alone. You follow up. You catch up with them and ask them about their story. Ask them, what did they see? What was this like? What did you perceive? Non-functionality means that they might come back and say, Mommy was there, but she was just sleeping. And I'll get into what to say and what not to say. But that's one thing that if the child is saying it, is a lot different than an adult saying, oh, don't worry, Mommy's just sleeping. If the child says it, let the child say it, but explore it with them. Explore, what do they mean by sleeping? Because we want to find out where they're coming from. Universality. At about 4 or 5 years old, they're going to start thinking, this could happen to me too. And then you have another issue entering in, and that is fear. Another set of questions. Why didn't I die? Why don't I die? Will I die if I get sick? Because Mommy or Daddy was sick. They were in the hospital, or they had to go to the doctor a lot. If I go to the doctor, am I going to die too? Tough questions, but again, the default response is somehow try to get back to listening to their story. Have them tell their story. Especially with infants, people say, well, this infant doesn't know what's going on. Cognitively, maybe not. But emotionally and affectually, they do. Infants pick up affect. Their radar antennas are finely tuned to affect. And mothers who have been pregnant have told me stories of how when their emotions have changed, they felt the baby move. When there was some type of noise on the outside at different stages of the pregnancy, they felt the baby move. We are blueprinted as human beings to survive. And in a child's mind, that blueprint kicks in the sense of their radar antennas pick up affect, because that's how they survive. When they cry, they can't say, "I'm hungry." They feel hungry, and so they let you know what they're feeling. And so children pick up, even infants, that something has happened at the time of death because of the adult's affect that they give off. And the child's radar antenna picks that up. Obviously, you can't talk with an infant, but the infant might be crying more. They might be more irritable. It might affect them physically. In the sense of there might be a sore or something that doesn't heal as fast, whatever. I caution to assume that just because a child is an infant and cannot cognitively understand these concepts of death, that they're totally isolated from the death experience, that we shouldn't pay attention to them. We should, no matter how old or how young they are. Latency age, those ages between 6 to 10 years old. One of the things that I want to highlight on my slide here is the behaviors. And this is what I was referring to in the beginning of caution that we don't assume that we're understanding where they're coming from or what they understand. So with this age group, there's a lot of times where they have a feeling, and by the way, by this point, they've understood those concepts of death, okay? So they know that mommy isn't coming back, that daddy's death was caused by something. But how they're feeling is difficult to put into words. It's difficult to know how to express, because death doesn't happen as often as other events where they can be happy or they can be excited or nervous or whatever. Death is an experience that is new many times to this age group. And so they have these feelings, and the reactions might come out in giggles, might come out in joking, in silliness, in being a prankster. And if you're working with this age group, you might hear a parent say, or an aunt or an uncle or somebody that's a caregiver say, "Don't be disrespectful." They're not. This is just the way these are the tools that they have to be able to express what's stirring inside. And so it's important for us to understand that, because if we don't, we, like many of the other adults in their lives, are going to miss where they're at. We're not going to understand what is going on inside, and then they carry that all by themselves. That's not good. I highlighted routine. And in my therapy, in my work with kids as well as adults, but especially with kids that have experienced the loss of a parent, routine means safety, security, predictability. So anytime you work with the survivors, those who are the caregivers for the children that you're working with, assess and emphasize routine. Oh, but they're still crying at night. Should we send them to school after 3 or 4 days of being out of school for the funeral and so forth? Yeah. Don't just send them and push them out the door. Work with the teachers. Work with the school administration. Do the extra steps of walking the child into school if that's not totally embarrassing for them. But to work with the child to make that pathway back as I don't want to say easy, but as comfortable as possible so that they can get back into a routine. Routine is essential in dealing with grief and loss. Teenagers. Here too, one of the pitfalls is that many teenagers will say, I can handle it. Don't worry about me. I would never encourage forcing a person to talk, but I would certainly recommend to adults to set up opportunities, invitations for a child to talk. So, once again, back to routine. A recommendation to the caregiver or the surviving parent to, on a daily basis, check in with the child and let them know that you're going to check in with the teenager. Let them know that at 7 o'clock in the morning, every morning, I'm going to ask you, how are you doing? You can just say, I'm fine, I'm off to school. That's okay. But I want you to know that I'm going to check in every morning. And the pitfall is that when teenagers roll their eyes, or teenagers say, oh well, or so what, or I don't care. I mean, I don't know about you, but that really, okay, fine, I won't ask at all. What I'm saying in situations like this, go beyond that. Why? Because there will be a day in a year, 2, 3, 4 years when all of a sudden that teenager is going to want to talk. And they know that you're going to ask at 7 in the morning because you've done it every morning. And after 2 or 3 years, now I believe that you're going to be there. I have this question. I have this feeling. It's unpredictable when a teenager is going to feel comfortable enough to talk with you. But it's our task as adults to keep after them, to keep bugging them. Not long, but just a question for 1 minute every morning at the same time of the day. That way they know that if that question or if that emotion surfaces throughout the week, that you're going to be there. You can come back to it. They will come back to it because they know you're going to be there. That's what's key in working with teenagers. Family assessment. When you come into a situation, talking with the surviving parent, talking with the surviving caregivers, how much do you want to be involved in the grief of your children? Sometimes the parent or caregiver just can't. They've got limitations. They cannot do it. So then you can step in with suggestions. First of all, step in and affirm for them that it's okay to have limits. You're a human being. One of the key suggestions that I would give a parent is, even though you're dealing with your grief, always make sure that you let the child know that they will be taken care of. So in other words, a parent, when you get flooded with emotion and tears come out because of a simple trigger of a can of pork and beans on the shelf because my spouse enjoyed pork and beans, And when I saw it, it just reminded me of him. And all of a sudden I noticed, there's my child seeing me cry. So what? Let them see you cry. But don't let them alone. Come back around and let them know that you're going to be taken care of. So depending upon where the parent is at or the caregiver, how much do they want to get involved with the child? What do the children know? How much have the children been involved in the past? What are their behaviors? And you go over all that I've gone through with the various stages. What are their stories? Cultural assessment. When we experience death and dying, oops, I gotta watch my time. When we experience death and dying, it is a non-negotiable event in our lives. And because it's non-negotiable, and because we have many questions as adults and multiplied as children, religion is a huge part of it. The key here with religion is whatever the child experiences, again, take them where they're at. I had a situation once where a young infant had died, and his 3-year-old sibling was seated on mom's lap. And mom said, "Don't worry, your little brother is with Jesus." And the 3-year-old says, "I don't want him to be with Jesus. He's supposed to be with us." Now, for some people, that might be a startling statement in the sense of, oh my God, that's not what our faith teaches us. That's not where the child's at. We have to take the child where they're at. So being aware of that, assessing where the child is at, assessing where the family is at. What are different rituals of body washing, wake service, afterlife, styles of burial. In some cultures, it's gender specific. Only the men go to the gravesite. The women stay at home and prepare the meal, and you come back. And that's another thing. Do you participate in that meal if you're there at the time of the death? That's something that you have to answer for yourself. But my recommendation would be to participate somewhat because it's more than food that you're getting. I want to shift gears to interventions. And, okay, I can't quite see. 5 minutes. Okay, good. Thanks. Interventions. Number one, create a safe environment. Create an environment that opens those floodgates of emotions, of stories. And so I'm just going to quick show you some things that I use. This is a wish stick, and it's in my bag. I've got a bag back here that I bring along, and all the kids know that. And they all go digging through it because it's not totally in order. It's kind of a mess. There's things in there like markers that are all dried out, so I got to throw them out, but they don't care. But this is one of the things they grab right away because it sparkles and it shines, and it's a wish stick. And when they say, well, what is this? And I said, it's a wish stick. And I said, all those little stars in there are wishes. And you can make a wish, and let's see if it can come true. So it's a way of getting out of them what's going on inside. Play-Doh is another thing. Creating something with their hands. Creating either an animal or a symbol, something gets them going. You can create their home and what it's like in this home, in your bedroom, now that mom or dad are no longer here. They'll have a whole story. Okay. What to say? Clarifying issues. Help me understand what this is like for you. So if they ask you a question about the death and dying, don't wait too long. Get right back to this question, to turn it over to them. Be truthful. If they're saying, I'm really sad, agree with them. Yeah, this is sad. I'm really angry. Yeah, you're right. This can make you angry. And even, I don't know the answer, but let's find it together. What not to say. It will be okay if you know it's not gonna. Say instead, this is not going to be easy. What do you think will be the most difficult or the most helpful? You shouldn't worry. It's like taking their feelings away from their experience away from them. Instead, ask them how together we can work on it. Everything will be the same someday. No, it won't. They know that. It won't be the same. Another thing at the funeral, some people say, oh, he's just asleep. No, he's not asleep. He's dead, or she's dead. And what it causes then the next time that child goes to sleep is, am I going to die too? I'm going to stop here with this self-care because the rest of it is on group. And like I said, I didn't think I'd get to it because I start talking too much. But there's so much information here to give. On self-care, don't underestimate the vicarious trauma. That working with children who experience death and dying will trigger memories of your own parents, whether they're alive or not. Will trigger your memories, your emotions. And that's the thing about death and dying that's non-negotiable. It will cause those reactions, those triggers. And so if we haven't coped with our feelings and resolved our issues of death and dying with significant people in our lives, believe me, our emotions will control us rather than we will control them. And the number one people that will pick it up are kids. So make sure that you take care of yourself because this is not easy work. Right.
Oh, good morning. Death and dying. It's a very tough topic. I know, I feel so, just listening to Peter and you guys listening to us, you feel morose, you know, you feel somber in spite of the sun coming out right now. Isn't it beautiful out there? You know why you're feeling that way? Because your definition of a child, your definition of children is going to YouTube and watching Charlie Bit Me. Have you seen that? You better go. It is so cute. That's my definition of childhood. Or I remember when I used to teach in Dearborn Heights, what I remember vividly is that Mrs. Smith, who is the first grade teacher, came to us and told us a story. And this is my definition of kids. Every time Mrs. Smith would ask a parent to bake a set of cupcakes for the first grader. And now it's the second time around, now it's the third time around that they're chowing on these cupcakes. Steve, who is a first grader, came up to Mrs. Smith and he said, Ms. Smith, you always say that these cupcakes are for Jesus' birthday. He never comes anyway. That's my definition of childhood. How many here are nurses? Wonderful. Okay, I see you. And how many here are our friends who are social workers? Wow. I can bet as well from counselors. Great. You know, I have this feeling that between nursing and social work and counselors, when I used to work at the hospital, I used to work at Detroit Receiving, Henry Ford Health System, and so forth and so on. I used to work in the emergency room. My first definition of multidisciplinary, in as much as we are, and even my talk is going to be complementary, or as a supplement to Peter's. What's very interesting is that that word multidisciplinary never came into my inner brain. What I thought of that was, once I take care of what I'm supposed to do as a registered nurse, then I pick up the phone and I call social work department. And they will go through questions number 1 to 100 all over again. That's multidisciplinary. Going and being a hospice nurse, going into the hospice world, at first it was very difficult. I said, hospice? Ooh, I don't want to do that. But you know, very interesting. I have learned to define what is it, why we are in this field, to make a difference. Remember that? During your interview, why are you coming into the social work? Why do you want to be a social worker? Because I would like to make a difference. Yeah, right. Excuse me. Same thing as a registered nurse. Why do you want to come to my unit? Because I'd like to make a difference. But folks, I think we should really make a difference. The way, this is a very tough topic, like what I said to you guys. So let me just pull up my, my PowerPoint. And just like with Peter, I would not be able to go through. There are 70 slides. That alone tells you I'm going to bore you to death. Okay? So let me give you the objectives. These are the 4 objectives that we will be working with for this presentation. But let me take you to this. It's not in your packet. Some of you have heard this. Be strong and brave. How dare you? You are the adult. You are the clinician. Aren't you trying to make a difference? Don't get me wrong, I'm one of those who said this in my practice as well. Oh, everything is going to be okay. It's not. The difference now, folks, is between you and I, all of us in this room, all of us who are watching right now. These are some of the no-nos. We are not sensitive by saying this, be strong and brave. Are they really? When you say to them, oh, mommy is on a journey. Oh, daddy is on a journey. Are they? That is out of reality. Oh, you'll be the man of the house now. It's very tough. It's very tough. Just remember, these are some of the slides that I just would like to, for you to see. Very interesting in the first bullet is that of the many life crises that a child may encounter on the path to adulthood, even just a serious or terminal illness or death, the death of a loved adult, big time. And this reality, obviously, we all know this already. These are all reinforcements. Maybe some of you have not seen it because you were absent when the professor have gone through this, or maybe you were nodding off. But let's think back, just like what Peter has said. The first death that you can remember is not only attached to a person, a close relative, or a friend. How about your pet? How about the pillow, the safety blanket? You're pulling it away. Can you translate that now? It's just an object. Translate that into a loved adult. Can you imagine what that kid, what children is going to be going through? The death of a parent will affect a child more than any other death. Okay, we all know that. And, you know, as usual, proactively as adults and as professionals, this will kind of like, we have proactively need to embrace the core principles of openness, honesty, and empower those who we leave behind. Now, I'm going to look at this from a nursing point of view. and it's not different from you guys. I'm looking at it from a nurse's point of view, obviously. I would like you to come into my world, into the nursing world. It's not as much different as you, is it? It's not different. It's just a matter of changing the terms. It's all semantics. So here in the nursing world, we use what we call as the nursing assessment, okay? And I will show you that. Everything is in your packet, okay? Nurses and you guys, social workers, nurses, counselors, we are all professionals. What I'd like you to do is we have to be uniquely sensitive to the ways in which a child responds to issues. Okay? Use family-centered assessment skills, and you have to pay attention to the impact on the child. And again, I keep saying this over and over, you and I should hold hands together. Okay? And we should be very concerned, and we should help all these people. Remember, these children in the future are the ones who's going to be taking care of us in nursing homes. We got to take care of them. We got to guide them to the right path. What I'm going to do is I am going to show you. Let me do this. The tendency for us is to shield away information. By shielding away the information, that means to say we're trying to protect them. Wrong. That's a big X. You can't do that. You have to be honest upfront right away, because it's going to fail. It's going to be counterproductive. And down the road, these are the things that you will encounter as a counselor, as a social worker, as a registered nurse. These are the things. Okay? All have moved on. In the meantime, the child's recognition of the loss is just starting. Not good. And this is very interesting. There's a lot of this that I'm going to show you, but the general parental illness alone, folks, is a significant factor. When a loved adult is sick, it is already a significant factor based on evidence in a population of adolescents with psychiatric disorder. Wow. How much more for the death of a parent? So we must approach this not as a multidisciplinary approach. Remember my definition of multidisciplinary. That is Barillo's book. Okay, don't be taking this and say, oh, this was... No, it's not. What I want you to pay attention is the word interdisciplinary. So if I'm a registered nurse and I'm taking care of a patient or a client right now, and I come to terms with a psychosocial issue, and that's not my expertise, I need to bring in a Peter Wolf. I need to bring in a Rita Turner. I need to bring in a Pat. I need to bring in Carol, who in their own world have this expertise. And Rod, who is a registered nurse, and this person who is a social worker, or Peter, who is very much a content expert, we, the three of us, will sit down, look at the plan of care. Now, listen, I'm using that right term now, plan of care, and see what we can do in order to guide this patient or client to a resolution. Work at the Occupational Health Center, or they work at Ford Motor Company, or they work at Wayne County Jail. This nursing process is the key that holds us all together, because it's the core concept of how we deliver care. Okay? So bear with us for a minute. Now, the nursing process starts with assessment, diagnosis, planning, and outcomes, implementation, and evaluation. What I'm going to do for the sake of this talk is not go through this whole 5 bullets, but I'm going to lump them into an assessment, diagnosis, the planning and outcomes, and the implementation. I will call it, in your world, interventions and evaluation, obviously. And the next few slides will tell you about the nursing diagnosis. This is for the sake of our colleagues in the other professions. Whereas I can show you assessment, diagnosis. Now, here's the asterisk on this one. Nurses are not allowed to medically diagnose. That I can tell you. That's not within our scope of practice. And as much as you guys introduced to me boundaries, this is out of our boundaries. Okay? We don't do that. Outcomes and planning, implementation, and evaluation. So basically, we are going to take the perception of a child based and using the nursing diagnoses. Here's the nursing process. Like what I said in blue, these are the ones that I'm going to pay attention to: the assessment, diagnosis, intervention, and evaluation. I'm also going to give you some clinical indicators. These are overall clinical indicators. Okay? Obviously, they will have a change in affect. They will have explosive emotions. Okay? There's going to be acting out behaviors. Expect that. Regressive behaviors, and I will go kind of like more in detail, okay, developmentally, and it's going to be age appropriate. There's going to be a change in socialization pattern. Obviously, is it my fault that dad died? Is it my fault that aunt died? Is it my fault that mom died? Will I die? Will I get the same thing? Okay? Obviously, physiological changes. And you have seen some of this from your clients already. Now, like what I said, I'm going now and take you into a nursing perspective. So we look at it based on assessment. The first step is assessment, and then interventions, and then evaluation. Okay? So let's start from a newborn to 3 years. What's the perception of that child? Obviously, they can sense, like what Peter has said, cognitively they cannot grasp it at this point. But they can sense if there is excitement, sadness, anxiety in the home. Okay, that's the perception. And they can sense if a significant person is missing. Obviously. Okay? They do not have any concept of death. They absorb emotions of others. All of these may exhibit in the way they eat, bowel movement, bladder movement, and it depends also on nonverbal communications. They give you all of these. This is what we put down in our assessment when we're taking care of clients or patients. What would be the interventions? Here are the interventions. It's in your packet. For a newborn to 3 years old, obviously you need to keep the normal routine as much as possible. There has to be a structure. Okay? Physically being affectionate to them, hugging, kissing them, they sense that. Okay? This is a form for them. You must exhibit the healthy coping behaviors to them. Now, let's move on from 3 years old to 6 years old. We're looking at assessment. What's the perception of a 3, 4, 5, and a 6-year-old about death and dying? They do not understand permanence. They thought it's reversible. They thought they just went someplace else and they're going to come back. It is temporary. It's just like going to sleep or a parent going to work. They know and they thought they're going to come back. And they have, like what Peter has said already, they are into this magical thinking. Okay? They believe that anything that comes out of their mouth becomes a reality. Okay? And sadly, they thought death is punishment for bad behavior. Well, I think it's not only for 3 to 6 years old. I know people in my circle who believe that still. So, based on an assessment, this is what it is. And they have these regressive behaviors, the bedwetting, the security blanket, the thumb sucking, okay, just like what I mentioned before. They have difficulty verbalizing, therefore they act out their feelings. They're more irritable, they use aggressive play. This is when you are being called in the principal's office, okay? You need to take this kid home, and so forth and so on. And they're only capable of showing sadness for short periods of time. Another one is they escape into play. And this is a repeat, somatic symptoms. They connect events that do not really belong with each other. And again, they may exhibit little anxiety due to belief that deceased is coming back. What are the interventions? Again, there has to be a structure. Keep the routines normal. Provide them the opportunities to play, to draw, read books, okay, on death and loss with a child. Help to verbalize the feelings and fears, and help to identify the feelings and reactions. Again, be honest. Use the right terms. Oh, they're just far, far away. Don't use those terms between a 3 to 6 year old child. What are the interventions? Again, I'm sorry. The interventions would be use, brief, and explain it in specific, concrete language. Don't use euphemisms as much as possible. Give them and gently confront the magical thinking. And make sure that the child does not feel responsible for the death. Look at the second bullet. Avoid those cliches. At least you have a pet. At least you have another brother. Those are being insensitive. Let's look at now from a 6, 7, 8, and a 9-year-old perception. They see death as a taker or a spirit that comes and gets you. They fear that death is contagious, and they will catch it too. And they're fascinated with issues of mutilation. They're very curious of what their body looks like. And they can connect that with violence, and they may ask who killed him or her. And they believe that there are only 3 categories of people who die. Hence, those 3. So you have to make sure to ask concrete questions, just like what Peter has said. Ask them, and where they're at is where you should begin. Here's another one. There will be school problems. They will defend against feeling helpless. They will be involved in fights at school. Or they might not even want to go to school. And obviously they will have to continue to have difficulty with abstract thinking, which is heaven, spirituality, religion, all of these terms. So what do you need to do? Interventions and evaluations. You need to talk to the child, with the child, ask questions, and make sure you let them know that they are not responsible in any way. Okay? And as much as possible, I don't know why I put it in here, normalize the feelings and the fears. What I meant with that is relative. Okay? Be very careful also when you tell them and use that word normal. Because for them, normal is they see mom and dad doing the usual routine, even though they're not here anymore. So I don't know why I put that in there. So I should put that in quote. And again, address their distortion and misperception. So be honest, help them share the bad dreams to you, and to you as a clinician, help them with positive memories of the deceased, and you model healthy coping behaviors. When I used to teach in junior high in Dearborn Heights, I'm talking about the last bullet here. How do you model healthy coping behaviors? It was a morning, a day that I don't want to teach. I used to teach grade 6 and 7. So I wasn't feeling good that day, so I took the ball out and took them to the field. And in between the breaks, you know how it is that the baseball players, they would spit on the ground and we'll play ball. So I spit on the ground. Did you know that one of the kids did the same thing? Happened to be seen by the principal. So now Steve is in the office. And Sister Constance, my principal, said, I need to talk to you. So now it's Rod in the principal's office. So I said, what did I do? Rod, did you know that they're pointing the fingers, those 3 boys, spit on the ground because you spit on the ground? So the upshot of this, the overall picture is that you think your kids are not listening to you. You think kids are not listening to us. They might show you this physical reaction that they're not listening to us. They are. Just keep talking, because they are. And whatever you do as an adult, they follow. Hence my story. So just would like to share that with you. Sometimes you think you're not connecting. Day 1, you think you're not connecting. Week 2, you think you're not connecting. You keep saying the same thing over and over again, and you think they're not listening. They are, based on studies and based on it was from NBC. What they have done is they have interviewed all these kids and they have given them all these tapes, and it's about sexual education. And you know what's very interesting is what they found out of that 8-week study. What they have found is that mom stopped talking, dad stopped talking. They think we're not listening, but we are. Very interesting, isn't it? So again, as you, as a professional, as an adult, it is our responsibility. Big R. It's our responsibility. And it's the right thing to do. For you and I to join hands and really guide them and help them to go through and get over this. Like what I said, this is a redundant, avoid cliches. You're such a strong boy, strong girl. Don't worry about it. Let's go now to a 9 to a 13-year-old perspective. What's the perception of death? Child's understanding is nearer to adult. Did you know that? And more aware of the finality of death and impact the death has on them. And 9 to 13 years old, they're more concerned with how their world will change. You know, who will go with me to the father-daughter banquet? They're more involved and more concerned about that. And sometimes they will stop questioning because they are getting a bird's eye view of what death and dying is all about. They understand. 9 to 13 year-olds, they have delayed reaction. At first, it seems as if nothing has happened, but it's deep inside. Okay, so be honest and be an active listener. I mean, hello, who am I talking to? I got that from you guys, working with my colleagues. You have to be an active listener. Sometimes clients and patients, all they want, especially in a hospice and a palliative end-of-life care setting, all they want is a face and a listen and a listening ear. That's all they want for that day. They know they're dying, or they know it's that their parents have died already. So, and then you gotta pay attention to their relationships. Sometimes it's disrupted. They don't want to go to school. They're acting out. Sometimes the relationship with their friends and their boyfriends and their girlfriends is marred. So pay attention to that, because sometimes that will lead to something negative. This is like what I told you already. Make sure to encourage discussion of their concerns. Allow for, I don't know how you would feel comfortable with this, but I know you would allow for regressive behaviors, but up to a certain point. And then you must confront it. Same thing. Avoid cliches. Big boys don't cry. Now, we're now going to a 13-year-old, 14, 15, 16, 17, and 18. What do they perceive? They're the same thing. It's an adolescent's perception. They have an adult understanding. They have an abstract understanding. And they have a concrete understanding of what death and dying is all about. They know death is an enemy. There are bodily changes that emphasize growth and life, and they know that is a contrast. And what's very interesting also with this group is that that is viewed as an interruption. Look at the second bullet. This could be problematic as well, because sometimes they will not snap out of it. It is your responsibility as a parent, as the adult, as a professional, to kindly go into this and involve and engage them, because they romanticize that. Because of death and of a parent, death of mom or dad, they will have difficulty with long-term plans. They will have somatic symptoms. They will question. This is interesting also, because this is a common thread among 13 to 18-year-olds. Even us, they start to question religion, the spiritual belief. They start to question God. They start to question things that you have told them, that if you're good, God is good. If you're not good, God will punish. Okay? And that is not true. So you need to intervene. So the interventions for 13 to 18 years old, don't assume that they can handle it themselves. Do not. Actually, be very patient as a professional, because somewhere along the line you'll get the break, because they will seek out help and support from you. So be available, but don't push. When I say be available, you have to be available. I know you guys, of all people, would be the one who should tell me boundaries, Rod, but sometimes it depends on case by case. I would share my cell phone number to them, but at the same time, because you don't know, it could be in the middle of the night that they would say, hey, I'm right here now on top of this bridge and I'm about to jump. That's where I'm coming from. I'm coming from the nursing perspective. But obviously, some of you would even disagree with that and say, no, you should know your boundaries. Well, having worked in the emergency room, what I do is I take care of the patient first, right away. I take care of them right away. Sometimes I'm not a pistol. Sometimes it may cross the line, but I'd rather be disciplined for having the patient alive than having the patient dead. That's in my own world. So sometimes it's a case-by-case basis that I would really share some of my information, like a cell phone number. If you need to talk to me, you can page me, you can call me, you can email me. Especially if you've been waiting and waiting and there's no break, that they would even seek out support, especially for teenagers, okay? Or what you could do is hook up with their trusted adults. Sometimes it's a teacher, sometimes it's a counselor, and sometimes it's another parent in the neighborhood. Again, give permission for regression, be honest. You have to be honest, be upfront right away. Don't hold this into your heart and against them and say, I'll probably let them know next week. No, you can't. Same thing when you deal with adults. These are teenagers. It's the same way that you deal with adults. Right now, I'm in a very tough situation where tomorrow some of my employees would not have a job. But I have been very honest with them that it's because of the climate, the environment that we have right now. But one thing I have learned is that I will always be honest. You know, honesty to me is the best policy. That's all that you can do, is be honest. Because in the long run, they will appreciate you being more honest than trying to shield that information away from them. So you must also assist them in relieving adolescents of burdens of adult responsibilities. Okay? And here's the last one as well. As an adult and as a professional, we have to guide them and as much as possible not to be involved in reckless behaviors. Okay? Again, here's the first bullet again. You need to de-romanticize death. You have to do that. And discuss feelings of helplessness. You know, when they go through this triad of helplessness, hopelessness, you know, they tend to go and say, and they take their own lives. You can't do that. What you need to do is you need to extend your hand to them and reach out proactively and help them out. And you need to model, again, the healthy coping behaviors. Now, Peter has already discussed this, which is the cross-cultural response. These are some of the bullet points that you need to ask yourselves as professionals. Okay? And folks, it is okay to ask. Even though they're mourning or they're grieving, it's okay to ask. What's not okay is not to ask and jump into conclusion and say, oh, he's probably quiet because that's the way they do it in their culture. And be sensitive, especially what comes out of your mouth. I put this as a personal, because a colleague of mine said this to me. Oh, you are already here in America. You got to follow the culture of America. And I said to him or her, I said to the person, what do you mean by the culture of America? Do you see? You have to be very sensitive what comes out of your mouth, especially at time of grieving. And again, it's okay to ask. It's okay to ask me. It's okay to ask Peter. It's okay to ask your client, your patient, or whoever is attached to that individual. It's okay. What do you do? Okay. In fact, on the other hand, now I put the I become so elated if you asked me, what is it that you do in your culture in terms of blank? I'm elated that you're asking, because you are professionally asking me, and it's a sign of respect. Same thing. What are the interventions for 13 to 18 years old? Again, be honest. I said this already and so many times. And mourning is culturally determined, folks. So pay attention to that. Here are some of the nursing diagnoses that we use in the field of nursing. Kind of like yours, you use the DSM-4. For us, we use a NICNOC that we call it. It's for nursing interventions and evaluation. So we use anticipatory grief for children, dysfunctional grieving, social isolation, altered role performance. This is not all-inclusive, okay? I just pick and choose which ones. Family coping, obviously. Impaired social interactions for adolescents. These are the nursing diagnoses that we use. We use nursing diagnoses, and based from these, we create and we build the plan of care with the client, with the patients. Again, there are no right answers. Be reassuring, be honest, and like what I said, being honest is painful. You have to think twice. Seriously, being honest is painful. Even in the face of tragedy, children can be prepared. They can weather the trauma. Those who are shielded from the truth can be permanently scarred. For evaluation, each patient, we see them as unique. You should ask yourselves as professionals, how can I support this patient and family today? Let me take you in the field of hospice and end-of-life care and palliative care. We all came up with all this DSM-4 in your world. In nursing, we came in the medical field, they all came up with the standards of what to do to a patient who's dying. You know what's the best practice now is? If a patient is dying or a family is grieving, we work with them. What is their goal today? Today. That's what's in the book. That's what in the CMS standards. How can I help you today? A patient could say, I wanted you to call my sister, my long-lost sister today. I need to talk to her before I go. That's the goal for today. Then I will work towards the patient's and the family's goal, not the clinician's goal. That's the patient and the family's goal for today. We'll work on it today. I can be the facilitator of that. I can help facilitate. Okay? What are they saying? What are they not saying? What are they feeling today? Talk to a child about death and serious illness. Use nature. They love this. Use nature. Use The Lion King if it's age appropriate for them. For all of us nurses who are out there listening, we got to be sensitive to nurses themselves. We have to be sensitive ourselves because maybe death and dying and grieving is a new concept for us. You've seen it in your practice, but when it hits home, it's different. So look in. What's your value system? Okay? Do you see some nurses, they view death and dying differently because for them the essence of nursing is caring and supporting the life process. Obviously, grieving and death is not a part of that spectrum, but that's changing. This one you like. This is from the perception of a child. For those of you, I will read it. Can't we just fly up to heaven and get her and bring her back when God is not looking? That's in their world. And lastly, you need to listen as professionals, as adults. You and I must join hands together to listen and listen with your heart. Thank you so much for being here.
Dr. Barillo, thank you, Dr. Barillo and Peter Wolf. We really appreciate your time this morning, and we've collected an enormous amount of questions, and I assume the same is true at our other sites. So we're going to do one question at each site and then cycle through. We have until 12. The first question comes from our live site here, and that is, sometimes the child is responsible for the parent's death, that is, perhaps played with a gun or set a fire. How do you work with these kids?
That's an excellent question, and it takes, well, first of all, I would work with that child individually rather than in comparison to a group. Sometimes groups are good for children in dealing with grief and loss because they can see other children's or hear other children's experience, and number one, they don't feel as alone. Number two, they might get a different interpretation of it. But in a situation like this, where, if I'm understanding the question correctly, the child believes that they are the cause for the death, is that right?
Well, the way the question reads is that they actually caused the death through either accident or perhaps on purpose. Okay. Playing with a gun, setting a fire are the examples given.
Well, you're dealing with a lot of guilt or anger if it's intentional, and so you're not only dealing with grief and loss, but you're dealing with all the issues that led up to, if it's an intentional homicide, those issues. And again, my point would be I wouldn't deal with that child in a group. I would deal with that child individually. Where do you start individually with that child? Tell me the story. Tell me what was going on. Tell me what's behind this. Again, depending upon, I'm assuming in this situation it would be at least a child of at least 10 to plus years old, in the sense of if it's an intentional death. What's going on behind that?
Thank you. We're going to take our next question from our Children's Center site in Detroit. Okay, there seems to be some issue there, so we're going to go to Lincoln Behavioral Services in Redford.
No questions here yet.
Thank you. Next, we'll go to Northeast Guidance Center.
Hello, Pat? Can you hear me?
Yes.
Okay. One question is what are different techniques to overcome a void or a vacuum when dealing with a grief and loss trauma issue?
Overcoming a vacuum, I'm assuming a vacuum in the sense of if I'm working with a child and all of a sudden there's just silence, or a vacuum of no talking about the death, is what I'm assuming from that question. So in other words, is that right? Is she hearing me?
Yes.
Yeah. So in other words, how do you stimulate conversation when the child is just quiet? Sometimes I'll start with being quiet with them. I think that's one of a very significant part of working with children is to allow for moments of silence. Another way is physically how I position myself with the child. So in other words, I'll get at eye level. So if we're sitting around a table, I'll sit on the little chair that they're, the same size chair that they're sitting on. I'll try to have something like the wish stick or the bag with all my puzzles and wish sticks, Play-Doh, all kinds of things in it that they can go through. So you just put it out there and see what they do with that. Because sometimes, again, I go back to what I talked about before, was that they might not have the words. They might not have the way of explaining what's going on inside of them. And so using materials that will engage them. And in the beginning, it might seem like, well, we're really not talking about grief or loss. We're talking about, you know, what's on this, this puzzle. That's okay. In order to build that trust with you, they might need to play with the toys that you brought or that you have in the office, or where maybe it's their toys as well. That's another way of getting into that void, in the sense of what are some of your toys? And usually they're laying around. So several things. Positioning yourself at eye level, having equipment, toys that, a variety of toys that they might engage in and just grab onto and start playing with. And thirdly, if there is a moment of silence, allow it to happen. If there is a void, allow it to happen.
Or between the 13 to 18 years old, or even the younger age, what you can do is initiate a conversation by focusing on some of the things that they like. Say, for example, the blanket, the security blanket, the safety blanket, and just make mention of, oh, I like the color. Where can I get one like that? So what you're trying to do is you're trying to look for a common ground, or a neutral object, or a neutral topic. For the 13 to the 18-year-old, if they're very silent, what you could do is you might know some things that they are very interested in. Like, say, for example, they're interested in math, or they're interested, yeah, right. They're interested in something else. Then
well,
try
sports.
To, yeah, in sports like lacrosse, and say, I heard something about that lacrosse. I don't know anything about that. Can you share that with me? Without going, you know, you got to create some stages, because just like what Elizabeth Kubler-Ross has said, yeah, they come in different stages. They come in, you know, you remember that, the denial, the bargaining, and so forth and so on. Same thing in opening up with this silence. What you're trying to do is not to promote the silence, but to break the silence and to break the vacuum.
Thank you. Next, we'll go to the Guidance Center in Southgate.
Hi, Pat. I believe this question is for Peter. It reads, you said an infant picks up on affect and may cry more or may be unable to be soothed. Does it follow then that the infant also could shut down and show no emotion?
Oh, that's a good question, because if a child at that age, infancy, shuts down and no emotion, there might be some other issues going on in light of attachment, in the sense of maybe lack of attachment. Because usually if a child is forming an attachment and you take that person away, it's going to cause some type of crying or some type of emotion, because you took their security away from them. You took that source of safety away from them. So like the question is alluding to, if you have an infant where the parent was taken away, I would want to explore and assess how much of an attachment did the child have initially with the parent.
Or let me extend that as well. If you see for a certain period of time that this is persisting, you might as well seek the help of a pediatrician to work with you on this in terms of the physiological changes.
But it's that shutting down that's a red flag for me if an infant shuts down emotionally, because they don't have a cognitive decision-making ability to say, well, I'm not going to cry. And if something, if they've lost their range of emotions, then I would say there's something red flagged going on with a lack of attachment.
Thank you. We're going to return to Children's Center.
Hey, can you hear me now?
Yes.
Okay. 8 years ago, my 13-year-old client found her 4-year-old dead on the couch during a house fire after being responsible for her siblings while mom was gone, saving most of her siblings. Now she is raging, ODD, and risky. How would one best proceed?
Well, definitely, that sounds like a situation where professional counseling is really recommended, in the sense that how do you proceed with that? I would explore initially what that was like for that 18-year-old to be responsible, and what responsibilities is he or she taking on that are, first of all, what are responsibilities that are distorted, that she had no way of controlling. Then also work with her on what are the responsibilities that she was responsible for or that she had control of that, due to the situation, caused the death of her sibling. That's something that, she's probably going to live with the rest of her life. And you deal with guilt, you deal with, self-worth, and that could take, it probably will take a long time to rebuild that in her. But where do you start? You start with her story, and what's her perception of that situation, and what are you want to clarify with her, what was she really responsible for, and what is she not responsible for?
Thank you. This next question comes from here at the Dearborn site. How do you intervene when someone close to you is not exhibiting a healthy emotional response, i.e. severe depression following the death of a spouse, and you see that it is impacting the child's emotional response to the death?
And I'm assuming it's the child that's experiencing the depression, right? That's how I'm hearing the question?
I think somebody in the child's life. Okay. So they're asking how the therapist would work with the family if members of the family, their own grief is impacting the child's emotional health.
Oh, okay. So in other words, the question pertains to both, like, one of the caregivers of the child is depressed because of the death, and it's affecting the child and the child's mental health.
Yes, that's my understanding,
okay.
Too.
Definitely I would work with the parent separate from the child, in the sense, because you want to deal with the depression that's going on with the parent. You also want to work with the parent not only on their depression, but what effect that they might be unaware of that is happening to the child. Like I talked about before, it's okay for a child to know and to see a parent experience emotions. But the key thing is that the parent needs to let the child know that the child will be taken care of, either by that parent or by someone that parent puts them in charge of. So in other words, the key message that you want to communicate to the parent is that you let that child know that that child's going to be taken care of. That's bottom line. Because if a child does not have a sense of security, they can't process the grief. If a child doesn't have a sense of safety, they won't learn, and that any teacher will tell you. If a child cannot feel safe, they will not learn or process the grief. And so you have to establish that safety. Now, if the parent is so depressed that they can't establish that for the child or secure that for the child, then you work with the parent on who can. It might be a grandma. It might be an aunt, uncle. It might be somebody else that they can team up with to help provide safety and security for that child.
Thank you. We're going to return to Lincoln Behavioral Services to see if there are any questions there.
Yes, there's a question. Where do you tell them the parent is and why they had to die?
I didn't quite catch that.
Where do you tell them that the parent is?
Oh, where do you tell them? Oh, great question. Yeah. Well, two things. One is, if a child asks you, where is mommy or daddy, you have several options. One option is you can just say, you know, I don't know. Where do you think they are? Again, because children many times aren't asking a question so much to hear an answer from you. They're asking a question so that you give them permission to tell them their story, to tell them what do they think where mom or dad is. But if they keep persisting and you're, let's say, the counselor or therapist, that's where you want to check in with what is the family culture? What message is the family giving the child? And so here's where you separate. Let's say I'm Catholic and I'm working with a Hebrew family, a Jewish family. And the perceptions of the afterlife are different. I'm not going to impose my religious beliefs of the afterlife. I'm going to ask the family and assess with the family, what is your story? What does your faith tell you about the afterlife? And then go with that and remain consistent with that. Here's where consistency is very important, especially consistency with who is the source of security and safety. What is the belief of the caregiver? Now, if the caregiver, like we've talked about what to say and what not to say, if the caregiver is saying, well, as an adult, I believe this is the afterlife, but what I've been telling the child is, Dad's just asleep. Then I'd work with the caregiver on picking out what are the very constructive qualities of their religious belief or whatever kind of belief they're coming from in the afterlife. Kind of cherry pick out what is good and healthy and what can be interpreted to the child so that the child can graduate from what they've told them in the past about being asleep, because that's a real dangerous statement, and move the child to a more consistent understanding with what the surviving parent believes.
Thank you. Next, we'll return to Northeast Guidance Center.
What is your technique for de-romanticizing death?
What is my technique for what?
De-romanticizing death.
De-romanticizing.
De-romanticizing death. That question, it's a great question, but there's so many things that come off of it. De-romanticizing death, first of all, my instant response is be honest about that death is... There is no reversibility to death. Let me back up. If the child is at that point, at that stage where they don't understand the concept of irreversibility, and they have a fantasy world about where mom and dad are, and that mom and dad are coming back. And if that's interpreted as the romantic perception of death, because that's where the child is coming from, that's where you start. And you let them tell that story. And in a sense, you might come back and say, well, do you let them believe something that isn't true, that mom and dad are coming back? No, but you work with them on their story and say, help me understand. Now, you said, this is mom and dad's home, and you go to this place called the cemetery. Tell me about, I don't see mom and dad. Help me understand that. It's kind of the approaching it from putting them in the teacher position and you in the student position, even with like a 3 or 4-year-old. But if you come with that head-scratching approach and say, help me understand, they'll give you key insights as to what you can focus in on and continue to, ask them to explain to you. And so that takes the romantic, the distorted perceptions and starts moving them in the direction of understanding that death, for example, is irreversible. Now, this doesn't happen overnight because they're only going to move from one developmental understanding of the concept of death to the next at their pace. What can we do is to continue to, and this sounds like we're repeating and repeating, but continue to get them to tell you their story. The fallacy that we as adults have is that we have to have all the answers. And when it comes to death and dying, let's be honest, we don't have them. And if we try to fake it, they're going to see right through it.
And it's okay to say, I don't know. Yeah. They will respect you more when you say, I don't know.
Thank you. We're going to turn to the Guidance Center for our next question.
This question is for Peter. In regards to the wish stick, do you consider it giving them false hope when they wish for something like their parent coming back? Where do you go from there? I understand that it's a conversation starter, but where do you go?
Yeah, that's a good question. Number one, at least you got them to make a wish, and that gave you an insight to what's going on in their head and in their perception. Number two, I go back to how I responded to that last question of you'll pick up things that they've said about that wish that you go, okay, you're wishing mom and dad to be, or you're wishing dad to be here for Christmas next year. How is he going to be there? I don't quite understand that. Can you help me understand? Oh yeah, I can tell you. He's going to be there because I got a picture of him and I'm going to put it under the Christmas tree. Oh, okay. So, or you might have a child. I mean, because children, they know when someone's gone. They get that. That isn't what's romanticized. What's romanticized is how they can resolve it in their head that somebody's out of sight, but they're still in my heart, and I still feel them because of the attachment. And I can't quite put those two together. And so, again, it goes back to continue to encourage them to tell the story, to do the wish stick, to... the thing is, I do want to add here about the wish stick is that you don't want to present it as it's a wish that is going to come true perfectly, okay? So you might get a child that says, well, I'm going to wish for Daddy to be back by Christmas. Christmas comes along and, boy, that wish stick didn't work. So you present it. How you present the wish stick is by saying, this is a wish stick, and we can make a wish, but sometimes the wish will come true in a way that we really didn't think it was going to happen. So when Christmas comes and you wish for Daddy to be there, let's figure out a way that maybe we can feel Daddy there. I've got a blanket from him, and I feel him there. I smell in a shirt that I have from him, his cologne. I can plant a tree this summer for him, and every time I go back there, that's where Daddy comes back to me. So you continue to move them in a direction of how can their wish come true, but also how can their wish be seen in a different light than just what they're focusing on, and that is the presence of Daddy at Christmas. That they can be broadened, their understanding can be broadened to Daddy being there in other ways.
Thank you. Let's turn to Children's Center next.
Okay, in your opinion, how is a child's reaction or perspective to the death of a parent similar to or different from the loss of parental rights? There's overlapping similarities. However, again, I go back to attachment issues. When I've worked with kids that the parental rights have been surrendered, the kids that I work with in those situations, many of them, to be honest with you, do not have an attachment to the biological parents because of what happened in the past that brought the state to take the rights away from them. And then you're dealing with the trauma. Now, natural death in and of itself is traumatic, but the death or the severing of parental rights and a relationship with the biological parent, that moment usually isn't the moment of grief or trauma. It's what brought in the history of their relationship to that point. And many times there's neglect, abuse, and those types of historical events. Boy, you're dealing with a whole nother ball of wax with that type of trauma. But is there a similarity? Sure, there can be a similarity in the sense that that parent is no longer in their life. But in those situations, I find that I do more work with helping that child attach to the foster parent or the adoptive parent so that that child has some attachment. Because, like I said, the cases that I've worked with, the majority of them, in fact all of them, there was no attachment. And so they know who their biological parents are, but there was no attachment. And really, there's very little grief. My experience has been there's very little grief if there's no attachment. I mean, we can read the newspaper today, and or like when I was driving over here, they announced the latest soldier that was killed in Afghanistan. Now, I feel sad because there's an attachment of humanity there, but I have no attachment of personal knowledge of this person, so my grief will not be the same as if it were my niece or nephew.
Mm-hmm.
Thank you. We have one last question, which is to please discuss the result of parental suicide. Particularly, they ask how to talk to different ages about it, and then the additional question regarding if a surviving parent doesn't wish the child to know that the spouse died from suicide.
Okay, boy, those are two. First of all, how to deal with suicide of a parent. You know, again, in the assessment, it's trying to figure out, is the child feeling guilt, and to what intensity is the guilt? I mean, are they taking total blame, or are they saying, boy, you know, I should have been able to be there to stop so-and-so from killing my dad, or from committing suicide. So it's assessing where they're at with that guilt, because many times there's guilt involved. The second part of that question, Give it to me again once more. My brain just went down.
The surviving parent doesn't wish the child to know that the death was suicide.
Yeah. Number one, you really have to respect that request. Again, depending upon the age of the child, a parent might say they're too young. At 3 years old, I don't want my 3-year-old knowing that daddy committed suicide. You got to respect that. If the child is 18 years old, then the approach that I take is, if you don't tell them, who do you want them to hear it from? Because at 18, they're going to find out. So who are they going to find out from? From you, or from classmates who read it in the paper, or whose parents know about it and talked about it and they picked it up? Who do you want to hear it from? And many times, what you're doing is you're reframing for the parent the networks of communication that can happen in the sense of where that child, especially at 18, where they can find out about it from. 9 times out of 10, almost 99.9% of the time when I do that, the parent says, well, I want them to hear it from me. Then I'll say, okay, how do we plan that? What are the reasons why you have some angst in telling them why the cause of death? And let's talk about that. Let's figure out a plan. So what you want to do is you want to figure out a plan with the parent so that you approach it as a team, so that, number one, so that the parent doesn't feel alone, but number two, so that you can give the parent options. Option one would be, do you want to tell your child alone? Do you want me to be there with you? How do you want to do that? Where do you want to do that? Do you want to do it at home, or do you want to do it in my office? Because sometimes people would rather do it away from home, because then if they do it at home, there's always that memory of it there. And where if it's in some neutral, private, confidential place, you can leave it there.
Thank you. And please, everyone, join me in extending a really warm thank you to Dr. Rod Barillo and Peter Wolf.
Thank you. Good job, Peter.